Washington Journal continues.
Joining us now to discuss the recently signed Halt All Lethal Trafficking of Fentanyl, or Halt Act, is Mazen Saleh. He is a Integrated Harm Reduction Senior Policy Director at the R Street Institute. Mazen, thank you so much for being with us this morning.
Thank you for having me on.
We'll start by having you tell our audience about the R Street Institute, its political point of view, and also how you're funded.
Sure. So the R Street Institute is a nonpartisan, nonprofit public policy research organization. We have a mission to engage in policy research and outreach to advance free markets and limited effective government. And the team that I lead at R Street are experts that conduct in-depth research on a variety of harm reduction issues, from tobacco use to opioid and illicit drugs to sexual health, and more often than not, how those interact with one another. We are funded by a variety of philanthropic and corporate donors, which allows us to be fully independent in both our research and our writing.
In both your title and your team, you just mentioned it, it's Integrated Harm Reduction Senior Policy Director. Explain the concept of harm reduction when it comes to public health.
Yes, harm reduction is a set of practical strategies aimed at reducing the negative effects of illicit drug use. Harm reduction really got its start in the 80s during the HIV and AIDS epidemic, when individuals who injected drugs started cleaning syringes. And so that was really where the harm reduction kind of ethos was born out of.
And it was a few weeks ago that President Trump signed legislation to combat the fentanyl crisis in the U.S. We're going to talk about that legislation, but before we do, where are we in this fight? Have there been any gains made the past few years?
There have been some gains made, which is encouraging, but we are cautiously optimistic. We are currently in the third wave of the opioid crisis. The first wave was around 1999 with opioid prescribing. The second wave hit around 2010, and those were when we started seeing overdoses involving heroin. Now the third wave, the one we are currently in, started in 2013, and that was with the introduction of synthetic opioids like fentanyl into the market. Now, for the first time since 2018, we are seeing a sustained reduction and deceleration in the number of overdose deaths per year. Since mid-August of 2023, so about 17 months, we've seen roughly a 30% reduction across the country, which is promising. Unfortunately, those reductions have not been evenly felt amongst a variety of populations. So Black and brown communities, indigenous communities, even older Americans. So there's still more work to be done. And unfortunately, probably as of data a week old now, we are starting to see upticks again in overdose deaths, primarily driven by increases in Texas and Arizona, in California, and in Washington.
And our topic is fentanyl. Explain what exactly that is and the impact it has on a body.
Yes, so fentanyl is a synthetic opioid. And so what it does when somebody either snorts, injects it, or smokes it, it acts like other opioids like morphine or oxycodone, in the sense that the medication binds to the opioid receptors in the brain. Now, when it does bind to the opioid receptors in the brain, it blocks pain signals, so individuals don't experience pain. It also increases the neurotransmitter dopamine, which is the reward part of the brain. And so that is the kind of euphoric high that individuals might experience. And so the combination of the blocking the pain and the euphoria is what makes fentanyl particularly addictive.
Our guest is Mazen Saleh. He is an Integrated Harm Reduction Senior Policy Director at the R Street Institute. Our discussion is looking at new legislation cracking down on the fentanyl epidemic. If you would like to ask him a question, if you have a comment, you can start calling in now. The lines for this segment are broken down regionally. If you're in the Eastern or Central time zone, it's 202-748-8000. If you are Mountain or Pacific, it's 202-748-8001. And I want to let you know we also have a line for those who have been impacted by the fentanyl epidemic, and that is 202-748-8002. And Mazen, wanted to talk about the Halt Fentanyl Act that President Trump signed a few weeks ago. Here is a look at some of the main tenets. It's permanent Schedule 1 classification under the Controlled Substances Act, stricter penalties for trafficking fentanyl and variants. That includes a 10-year minimum for possessing 100 grams or more of fentanyl or fentanyl-related substances. It also facilitates research on fentanyl and fentanyl-related substances. Does this law and its provisions adequately address what we're seeing when it comes to the overdose crisis that you were talking about?
Yeah, so we don't think it actually adequately addresses the fentanyl overdose crisis for a variety of reasons. The first of which is this is not a new thing. So the first class-wide scheduling actually took effect under Attorney General Jeff Sessions in the first Trump administration. It was a temporary order to extend class-wide scheduling to all fentanyl-related substances. And so we have 5 years of experience now with this law kind of on the books. And we are still seeing the most volatile drug supply in the United States, the most toxic and lethal it's ever been. And in addition, we saw overdose deaths really peak in 2013 again at 115,000 per year. So it's safe to say with 5 years of experience that the legislation as crafted is not making the impact that was hoped for.
We have callers waiting to talk with you. We will start with Gerald, who's in Fayetteville, North Carolina. Good morning, Gerald.
Mr. Saleh, C-SPAN America. Good morning. How are y'all on this beautiful day?
Good, thank you.
All right. I'd like to have a brief follow-up, if I could, after I ask him, because I'm speaking for a large subset where this particular policy has really hurt. First of all, I'm a known elderly, physically disabled patient, negatively afflicted with severe chronic non-malignant pain. After 40-plus years of being perfect, no problems at all in my record documented for any abuse to anything. Yet after a singular abnormal type screen, which was proven to be wrong for THC, nothing serious, and I don't smoke because I'm allergic to smoke and stuff like that, I was kicked off. Now that forces us with what's known as a Hobson's choice. Do we suffer? Do we go to the dark side of the street to self-medicate? Or do we contemplate worse? I have the appropriate empathy and sympathy, or we do, for those who have suffered from the negative effects of this particular medications or similar. But what about those of us who this type of medication is appropriate and necessary? It seems like these, based on their actions or lack thereof, certain clinicians seem to have been trained at the Joseph Mengele School of Medicine with advanced training at the Marcus D. Sod Institute of Pain Management. The question is this: please enlighten us, the subset of the group who have done nothing wrong for 40 years or more due to illness like paralysis and things like that. Where do we go? And I'd like to have a brief follow-up because everybody seems to dodge these questions when we ask them. Please respond, sir.
Yes, I'm so sorry for the pain and the situation that you are dealing with, and you are not alone in that. There's a number of pain patients over the last 10, 15 years who have been in similar situations. And this really kind of stemmed from when the Drug Enforcement Administration started clamping down on how physicians prescribe opioids. And so we find ourselves in a situation, and we certainly did back in roughly around 2007 to 2010, where individuals were out of options to manage that pain and certainly went to the illicit market to do so. And so it really brings up, it really legitimizes, I think, what we call the iron law of prohibition, right, which is as enforcement gets greater, the substances involved also become more potent. And so really that clamping down on the opioid crisis or the opioid prescribing in the early 2000s really led to the situation that we are in now. And
Joe, go ahead with your follow-up.
Okay, basically as this is, we're the ones who basically there's been a casting, overbroad casting of the net because certain doctors and certain people manipulated the system, and those of us who have done nothing wrong are being abused. Is that basically what the result is?
That is the result when we start thinking about class-wide scheduling, and that is the dangerous precedent that's set when we permanently schedule all potential substances under the Schedule 1 classification of the Controlled Substances Act. Now, Schedule 1 essentially indicates that these substances have no medical use and they have a high potential for abuse. Now, historically, in order to schedule them using that classification, each substance would be studied and analyzed on its own merits and the risks that it posed to the population. And so, unfortunately, that is the situation we find ourselves in when we only focus on supply-side interventions to address the opioid crisis. And those supply-side interventions really home in on criminalization.
Let's hear from John in Wilmington, Illinois, on the line for Impacted. Good morning, John.
How you doing? I'm pretty upset at what I'm hearing from you. I hear nothing that gives Donald Trump credit for his public health emergency, his opioid commission, and the Support Act, which actually pays doctors a bonus to torture us patients. I'm a chronic pain patient just like that other gentleman. As far as the impact, I buried a brother, a sister, and a daughter, all because of untreated pain, and they ended up going out to the streets to get some kind of relief. All of these people got cut off from their medication while they were still in pain. I was poisoned by a statin in 2012 and developed inclusive body myopathy. The only drugs available for this incurable and untreatable disease are opiates and amphetamines to give me the opportunity to function. After Donald Trump decided that he was going to manipulate the CDC dosage guidelines that were written specifically for new, naive patients, and manipulated those guidelines to establish prosecutorial justification for Jeff Sessions' DOJ, DEA, things started hitting the fan. All of a sudden, I got caught off. I'm married to a doctor. I got caught off. I had to prove that I still have inclusive body myopathy. You go run a mile, I'll sit on my behind, and guess what? My CPK will be 10 times higher than yours. That means that my muscles never stop running. If I don't have medication, I can't swallow. I can't breathe. I've lost a house. I've lost all kinds of financial deals. I'm involved in a multi-million-dollar lawsuit, and even after Illinois passed HB 5373, which basically freed up doctors to prescribe as they saw fit without having to fear any kind of legal ramifications from the federal government, I'm still being tortured. So I want to know, after reading through your website as classic liberalism, why are we giving credit to the man who increased overdoses by 350% from 2017 to 2018? The same man who took all kinds of credit for reducing opioid scripts by 50% in his 2020 campaign, and now doesn't mention nothing.
John will get a response from our guest.
I want to begin by saying how incredibly sorry I am for the multiple losses that you suffered. That is an unimaginable tragedy, and I can't really fathom that sense of loss. But you're touching on something I think that is really important to highlight, and that is what happens when the federal government gets involved in kind of the prescribing guidelines and also the role that it plays kind of in the patient-doctor relationship. I will say that the overdose crisis has been contributed to for the last 30 to 40 years from a variety of administrations that vary the political spectrum. From Nixon and the start of the war on drugs that had that enforcement first strategy to George Bush and Bill Clinton, Biden and Trump. And so we continue to see the same types of interventions that are promoted that over the past 50 years or so have resulted in the most toxic drug supply that we have and the most amount of overdose deaths that this country has experienced. So we think it's really time for a new way, and that new way involves demand reduction interventions. And so those are things like harm reduction. It is things like getting naloxone, which is the opioid overdose reversal medication, commonly known as one of the brands, Narcan, getting that in all communities, so community saturation of that. And something that we haven't talked about today, which is expanding the treatment infrastructure of the United States. Now, there have been some recent actions by this administration and this Congress, unfortunately, that are moving in the opposite direction of being able to expand that treatment infrastructure. But in order for us to be able to treat the amount of individuals with substance use disorder or dealing with pain, things of that nature, we need to really refocus on those demand side interventions.
Let's hear from Dee in Connecticut. Good morning, Dee.
Good morning. Thanks for taking my call. I just have a brief question, and that is, given the fact that fentanyl is so lethal, how does the government dispose of the massive amounts of fentanyl that it seizes? And also, is there a chance that this seized fentanyl can turn up in our food or water supply if it's improperly disposed of during the disposal process? Thanks.
So I'm not an expert on kind of the disposal of those illicit drugs. I think what we have seen when the federal government disposes of medications, whether licit or illicit, is it's usually through incineration, so burning those medications. But I can't speak to where that is done or the impact on the environment that might have.
Mazen, you touched on this, but this question came in on X from MLB, says, what are some of the most effective programs to fight drug abuse? We never hear about them. Are there any programs that are highly effective that target fentanyl abuse?
So the first thing is the gold standard treatment for opioid use disorder, which are medications for opioid use disorder. They include two particular medications, buprenorphine and methadone. Out of the millions that are suffering with substance use disorder, only a fraction, roughly 6.3%, have access to those medications. And that's for a variety of reasons. Methadone is extremely regulated. You can only get them in opioid treatment programs, and opioid treatment programs are not spread evenly geographically throughout the United States. And so for individuals to be able to take their dose of methadone, oftentimes they have to travel a few hours each way to be able to do that. And if they have multiple doses throughout the day, you can imagine how much interruption that is to trying to hold down a job or feeding a family or taking care of kids. Buprenorphine is available through physician prescribing, but what we are seeing in pharmacies across the United States are that it is actually not being dispensed as much as it could be or prescribed, and a lot of that has to deal with stigma around people who use drugs and their appearance in pharmacy settings.
Stanley is in Delaware. Good morning, Stanley.
Good morning. I'd like to thank C-SPAN for the format.
Go ahead, Stanley.
Oh, yes. My first question is, what are the total opiate or opiates overdose deaths during the 3 waves of the overdose events that you talked about? And the second question is that research has noted that the overdose deaths have decreased. And the myth or urban legend is that there's a burnout rate, or we're just running out of people, or it's running out of people to kill.
So in response to your first question, with the three waves of the opioid crisis, so if we stretch back about 25 years or so, what we are actually experiencing is nearing 1 million lives lost, which is an astronomical figure. And regarding your second question in terms of the reasons for the current deceleration of overdose deaths across the country, researchers are trying to pinpoint what exactly that is, but it's not one particular thing. We think it's a combination of things. One being that the supply itself is changing. To give you an idea of how volatile the drug supply is in the United States, there's a great researcher at University of North Carolina. His name is Dr. Nabaran Dasgupta, and his lab at North Carolina brings in and tests street drugs from around the United States. And his lab has found 400 unique substances in the U.S. drug supply. And so part of the reduction could be the shift in how fentanyl has spread across the country. Now, work that we have done at the R Street Institute also shows that shift where fentanyl really was, involved in opioid overdose deaths starting on the East Coast and then working its way westward. And so that's one particular reason. The other reason is the frequency of naloxone in the community. And so there's been federal efforts to equip first responders and other kind of institutions. There's been activity at the state level to get naloxone in schools and community centers and public parks. And so that is really the community saturation that we talk about when we want naloxone, the opioid overdose reversal agent in the country. And then the third, which you touched on, which is the more devastating statistic, is that the people that would be most vulnerable to overdose have unfortunately succumbed.
And you just mentioned one of the drugs that can be used to revive those. This question coming in from Barb in Long Grove, Illinois. She asked, would Mr. Saleh have information regarding Narcan availability for the general public to use in emergency situations?
Yeah, so Narcan received over-the-counter designation from the U.S. Food and Drug Administration about a year and a half, 2 years ago. And so it should be available in retail pharmacies. If you don't see it on the shelves, I would certainly ask a pharmacist or a front desk attendant to get that Narcan. The second is Narcan has a very easy-to-use auto-injector, and there's actually an insert in the package that shows you how you can administer the drug and what you should do in terms of waiting times. And so it should be available. If it is not available in retail pharmacies, I would encourage you to reach out to community health centers or harm reduction organizations that you might be close to, and they will have that information.
You just mentioned community health centers. We've done segments looking at how they have been impacted by cuts to the federal government. When looking at the fentanyl epidemic, what does the impact spending cuts have on addiction-related public health and science programs, including funding for Medicaid?
The cuts are going to have a pretty dramatic impact, but it's not going to happen all at once. And the reason they're going to have a dramatic impact is there have been staff reductions and funding reductions at the Substance Abuse and Mental Health Services Administration, known as SAMHSA, at the Department of Health and Human Services, the Human Resources and Services Administration. So these three federal agencies really do a lot of kind of grant funding to communities and states across the country to address some of these issues. And also what's looming quite large are the deep cuts to Medicaid that are anticipated. Now, Medicaid has around 71 million enrollees, and out of those, around 21% qualify for a substance use disorder, whether that is alcohol or illicit drugs. Now, out of those, so because of that sheer volume, Medicaid is the single largest payer for substance use disorder treatment in the United States. And so we can certainly expect reductions in staff, reduction in funding to really affect naloxone reaching community centers, equipping first-line responders, and really starting to limit how individuals can get medications for opioid use disorder if they are in treatment, how opioid treatment programs are paid through insurance schemes, and the sort.
Byron is in Wilson, North Carolina. Good morning, Byron.
Good morning. I got something that nobody's thought about, and it's so simple. We are 4% of the population, I'm saying the United States is. We consume 50% of the world's illegal drugs. We are a sick nation mentally. Nobody's looking at that. Even with our politics, we're getting sicker and sicker now mentally. It's affecting me. And so when you look at this, you got to look at, if we could stop all the fentanyl from coming in here tomorrow. If you are a sick mentally nation, and every nation is, but we are over the limit. If you're a nation like that, people are going to find something to ease their pain. And you can stop the fentanyl, but you'll get something else to take the fentanyl's place. Now, we're spending all this money to stop the fentanyl from coming in. Now, if you was an addict, you sitting down here, you need something. Oh, I can't get no fentanyl. You don't think they'll come up with another synthetic drug. You are putting Band-Aids on the problem. We have been doing it for years, and nobody's looking at the real problem. And we, like I said, we are a sick nation. And one other thing, C-SPAN, that I want to tell you, please listen to this, and it's good advice. You had a show on the Israel thing, I think it was yesterday, the day before, and the guy you had up there was a professional talker, and all he did was filibuster. You had 3 calls to come in from people. Now, you'll get these people up there that can run their mouth and influence you, and you just let them go on and on and on. And you don't let the people that's calling in talk. I said, that's a shame. And then you didn't have no one up there that's telling the side from the other side of the story. So y'all guys getting better, like that caller said the other day, but you still can go a lot further. And if you don't do this, you're going to end up being just like Wall Street Journal and all them other stations, and you're going to be, if you're not already influenced by the people that own all of our media, you're going to be in the same boat they're in. You got to stand up and be the people's station. And, you know, I hope you do, but I really want everyone to look at our sickness here in this nation and think about it. If you took all the fentanyl away, what would happen? All these people would come straight? No. You got to go to the problem, to the root of the problem. And we seem to do this with everything. And I would like to see you have a show on Haiti because we got...
Okay, Byron, we're going to get a response from Mazen.
I believe you're touching on something that's extremely important and one of the reasons why I'm here today, which is to really advocate for an intensive focus on demand reduction. And so we can do as much as we want trying to reduce the amount of drugs that are coming into this nation. But until we really address the demand, that's really going to be for naught. And ways that we can certainly do that is ramping up our mental and behavioral health workforce and ramping up our treatment infrastructure. Individuals who want to access treatment today can't access treatment for a variety of reasons. It's out of touch, it's too far, it's too expensive. And so we need to make treatment affordable and accessible to all in that sense. And you have really good comments on what is, fentanyl today might be something else tomorrow. We are seeing research emerge from Europe right now and the introduction here over the last 15 months or so of a ultra-potent synthetic opioid called nitazene, and it is up to 5 times more powerful than fentanyl, which again talks about that iron law of prohibition. The more we focus on enforcement, the more compact and potent the substances that we're trying to enforce are.
Let's hear from Robert in Utah. Good morning, Robert.
Good morning. Yeah, Mazen, I just had a question concerning the use of fentanyl and these other drugs here in America. Why are we always so defeated by this in America, and how do we compare statistically to other parts of the world in, developed nations? Why is it just an addictive society problem, or is it a fentanyl problem?
Currently, it is a fentanyl problem. Fentanyl isn't shipped as much, or there isn't really a demand for it as much as other developed nations. In addition, there's a variety of other factors that contribute to the treatment of individuals with substance use disorders that might be more resourced or more sophisticated in other nations. And so it's really a combination of factors, but in the United States currently, it is fentanyl, just given how supply chains for drugs are conducted.
During last month's bill signing, President Trump touted the harsher penalties for drug dealers. This is a question Ellerby sent in on X. Says, knowingly trafficking fentanyl should result in capital punishment. What punishment do countries with low or no drug problems use that is successful? Fentanyl is as effective as any assault weapon and results in what I believe is mass murder.
Yes, so really that is representative of the enforcement first approach. We have had, fentanyl and other extremely potent substances have been prosecuted for a number of years. And so what we tend to find are the harsher prison sentences tend to result in scooping up lower level dealers, so dealers on the bottom of the totem pole of the drug supply chain, and those individuals more often than not also have substance use disorders, and so rather than pushing them into this endless cycle of incarceration, potential for higher overdose once they come out of incarceration, and then back into the social network of dealing with illicit substances again, because now they have a criminal record. They can't get a job, they can't afford housing, things of that nature. It's time to really kind of take a different approach and really start rehabilitating individuals by ensuring they have access to proven treatments to address substance use disorder. And the reason why other countries are a bit more successful in it is really the gold standard treatments and medications that I had alluded to earlier. So buprenorphine and methadone are not as restricted and regulated in other countries than they are in the United States.
Couple minutes left. We'll get in a couple more calls. Mike in Strawberry Plains, Tennessee. Good morning, Mike.
Good morning. Thank you, C-SPAN. Just a couple of questions for your guest. To be honest, right with you, I'm a lifelong drug addict. I know I'll always be that. But when I was young, I did it for the high. And as I'm older, I understand some of the drugs that I did help with my chronic pain. But back to the first question I have for him is, why hasn't he talked about the responsibility of the person taking the drug? You have to take responsibility for your actions. Even though I understand greatly what he's, the program's about. And the second question is, I'm older. I say older. I'm a senior. In chronic pain, I have never asked my doctors for a pain pill because they want to give me the opiate, which makes me, I'm not allergic to it, but it makes me sick. I'm sorry. So I'm not going to take that. But I do have the right as a human, as whatever you want to call us, or why we have the right. Is this the rest of my life? Am I going to be pain or in pain, this chronic pain that never stops 24/7? Am I going to be that kind of person that is in pain for the rest of my life? Why can I not get a straight answer from doctors, physicians, surgeons? And so maybe he can answer my question, and I'll hang up and listen to his response. Thank you.
I'm sorry that you are in pain and that is the situation you are experiencing with your providers. I think you bring up a really good point on personal responsibility. There are a lot of things around the ways that we address drug use in the United States that actually strips individual autonomy and personal responsibility and decision-making from the individual who is using drugs. Part of that is a byproduct of the war on drugs mentality, the over-criminalization of the wrong types of drugs versus the right kinds of drugs. And also that really starts bleeding into stigmatizing providers who are prescribing these medications for individuals like yourself who are dealing with pain and pain management. And so we're finding that providers are, concerned that they're going to be flagged in systems that moderate prescribing of opioids and other pain medications in the United States. And so really, I want to pinpoint how important it is that as we craft laws to address the overdose crisis in the United States, that we put individual autonomy and personal responsibility at the forefront and give individuals options, which is, I think, the most important thing to be able to live a better and safer life. And part of that is making sure that they have access to medications for opioid use disorder, access to syringe service programs, and other harm reduction interventions that can keep them safer while they are on that journey.
Susan in Clarksville, Tennessee. Good morning, Susan.
Hi, good morning. I'm in the recovery field. I'm a recovering alcoholic. I haven't had a drink in 16 years. But 10 years ago, I had a boyfriend. He was dying of cancer, and the hospice finally came in, but they left bottles of liquid fentanyl or morphine, patches, all kinds of patches. And when he finally passed, there was no accounting for the medication that was left. And I said something to the lady, and she just stuck all the patches on toilet paper and flushed it. And I was like, oh, man. And with the baby boomers getting older and grandma and grandpa with their pain medicine in the bathroom that anybody could get a hold of, I have a feeling it's going to get a little worse. I kind of do wish they would legalize marijuana to help with people's whatever's going on. I hear it helps with pain. I don't smoke it, but I don't know. I just worry about the baby boomer age getting older, and it might have an uptick of these drugs.
I think what we are seeing are older Americans are increasingly more susceptible to overdose deaths. I will say that with the clamping down on opioid prescribing in the late 90s and early 2000s, we should be seeing less and less of large amounts of fentanyl and other opioids being prescribed and left available. And so I will say that there is currently research right now to look and try and discover new drugs that are not opioid derivatives to help to deal with pain management. And so that is something that we are watching closely.
One more call for you. It's Kathy in Murrow, Ohio. Good morning, Kathy.
Good morning.
Go ahead, Kathy.
Yes, I was calling to talk about, he was saying back in the 90s and 2000 that they cracked down on the doctors over prescribing opioids. And then after that, everybody started going to the clinics, which I am in one of the clinics. And they're talking about taking federal fundings from the clinics if they take the federal fundings from the clinics and the doctors are not allowed to prescribe anything to keep you comfortable, what are people like me supposed to do? And also, I have a friend who is very ill and was on pain medication, and his doctor just cut him off completely. And he went to the streets to buy drugs, and he got some fentanyl, and it killed him. Now, I don't want to be one of those people, so I was wondering, what are people who are in the clinics, what are we supposed to do?
If history is any indicator of the future, I think, unfortunately, we can certainly expect some also devastating incidences. I'm so sorry for the loss of your friend. And I think that, we can't talk about treatment and recovery as a nation while simultaneously kind of dismantling some of the infrastructure pieces that are required for treatment. And so proven effect interventions like syringe service programs and things of that nature are really helpful to being able to connect people to the care they need and eventual treatment. Dr. Dasgupta, who I had mentioned a bit earlier, had a really intriguing and I think innovative thing that hasn't been quite as discussed as much, which is it time to move on from a national drug control policy to a regional drug control policy, or a state or a city-based drug control policy, just given the volatility of the drug supply, the use patterns that vary from jurisdiction to jurisdiction, and the solutions that can be better tailored at the community level than they can at the federal level.
Mazen Saleh is the Integrated Harm Reduction Senior Policy Director at the R Street Institute. You can find his work online at rstreet.org. Mazen, thank you so much for being with us this morning.
Thank you for having me.
We are wrapping up today's Washington Journal with more of your calls in open form. You can start calling in now. The lines there on your screens: Republicans 202-748-8001, Democrats 202-748-8000, and Independents 202-748-8002. We'll be right back.
American History TV